So now we're at the drug elimination part of the ADME, of the absorption, distribution, metabolism, and now the elimination of the drug. And so the way that drugs get eliminated is primarily through the kidneys, into the urine, the liver into the gallbladder, into the bile duct, and that moves it into the back into the intestinal tract and into the feces where it's eliminated that way. The lungs can be the route of elimination, especially for our inhalant anesthetics. And then less commonly, drugs are sometimes eliminated in saliva, milk, and sweat. And the importance there is mostly in the milk because drugs that are eliminated via milk, if we have animals that are being milked, we need to be very aware of which drugs are going to be eliminated that way, or at least partially eliminated that way, and the milk cannot be used for human consumption. So those are what we talk about with withdrawal times for those types of drugs. So let's talk about renal excretion of drugs. And I have a video here. If this is helpful, please watch it. It kind of goes through this process in a whiteboard type process. Animation is what I'm trying to say. It is it kind of shows you how things go in an active way. I can't do that with this PowerPoint, but I think that you all are probably about to start talking about this or will be talking about it soon. So I'm going to give you the Reader's Digest version because that is what you need for this particular part of our course. So the basic idea is that blood with waste, in this case with drugs, comes into the kidney, and it is going to be filtered through the kidney and leaves through the, so we're coming in with the arteries, we're leaving out of the veins from the kidney. And that which is filtered out goes into the waste, into the urine, and out through the bladder. So the initial part is, I'm going to advance to the slide. The initial part is the renal artery coming in, this is a branch of it, coming into the glomerulus of the nephron. If you notice, this part of the artery is slightly larger than this part. What that does is it puts more pressure for things, fluid and small molecules such as drugs, to be filtered out into this part of the nephron, which is called Bowman's capsule. So it's just a pressure thing, just pushing it in there. This is the start of the renal tubules. So this is the proximal convoluted tubule. This is the loop. Oops, I'm sorry. Let me go back up. This is the loop of Henle, descending, ascending, and then the distal convoluted tubule, which then leads to the collecting ducts. And everything that has stayed in this far or been brought in to the renal tubules leaves as urine. You'll notice the tubules are surrounded by arterioles and venules, capillaries in between. So just know that things can move between the blood vessels and the renal tubule, and they will move in and out depending on some active transport mechanisms and diffusion in different areas. And things that then we've filtered them, this is the glomerular filtrate, into the renal tubules. If they go back via one of these mechanisms into the blood vessels, that is called reabsorption. So that's kind of the basic setup here. So most of the drugs that are not protein bound are going to be filtered into the renal tubules. They're going to go into the glomerular filtrate. Proteins are going to play a role in this. So if they are protein bound, typically those are too big to be filtered out. There's some other ways, though, that drugs can be effectively removed from those proteins in those blood vessels that are still surrounding the nephrons. We're going to talk about that. or the renal tubules. And if we have a decrease in plasma protein, that's going to allow more drug to be filtered out and to be eliminated. It's also going to have an effect on the drug while it is in the animal system, in that there will be more active drug that is not protein bound, but it will be eliminated more quickly. So if you think about what causes perfusion of the kidney and what might decrease that perfusion, uh, it's going to be things like low blood pressure. And things that cause low blood pressure can be a failing heart. It can also be blood loss that would cause a decrease in blood pressure if we have open bleeding. And there's a few other things, but those are the main things that can cause low blood pressure, which would then lead to a constriction of the renal artery. And this is set off by the sympathetic nervous system, because the sympathetic nervous system is what comes into play when we're going to have fight or flight. And that is also going to cause a constriction of blood vessels to keep the blood is circulating around in the body so we can run away or fight our enemy. And the same system, autonomic nervous system, comes into play when we have a decrease in blood pressure. So that decrease in blood pressure is going to equal a decrease in blood flow to the kidneys and to our filtration system. So more drug is going to stay in the body because we're going to have a decrease in the filtration system. So if we have anything causing that decrease of kidney perfusion, we want to think about decreasing the amount of drugs that we're going to be giving the animal until we can get this situation to be more normal, simply because more of that drug is going to be staying in the system and less will be filtered out. So on the other hand, we have some situations where we might increase renal perfusion, and that includes things like this kitty cat is getting some sub-Q fluids. They're going to be absorbed. This is a very passive kitty that's allowing. We're just putting a large bore needle under the skin, and we're going to give the fluid sub-Q. It's going to be absorbed. But if we were giving IV fluids, we would certainly have an increase in renal perfusion. This will eventually occur in this kitty, but more commonly in giving an IV to a kitty that is going to allow more renal perfusion, more drug to be filtered out. So we might have to add more drug for a situation where we're giving an animal IV fluids. So once we get this glomerular filtrate, it's going to enter the proximal convoluted tubule of the nephron. And this is just a contrast urogram where we've given some contrast material to this animal, and it's lighting up this part of the nephron. So I'm going to use this acronym PCT for proximal convoluted tubule. So I don't want to lose you through this part of this talk. So in the proximal convoluted tubule, sometimes for some drugs, we have carrier-mediated transport molecules that will allow, remember the blood vessels are in close proximity to the proximal convoluted tubule, and so these carrier active transport systems, if they have a great affinity towards even protein-bound drugs, they may bring them across into the proximal convoluted tubule from those blood vessels surrounding them. So it's just a transport system that can bring it into the renal tubules. And we use this to our advantage in the case of penicillins. Penicillins are actively transported into the proximal convoluted tubule and are very good for treating bladder infections. So they are just brought right in, go into the bladder, and can treat that infection. It's important to know that energy is used for this process. So if we have any problems with the animal and getting enough energy, that might not happen. So the thing that happens is if we have a large affinity for protein-bound drugs, to these carrier molecules, they're going to bring them across. If the attraction isn't really there or it's pretty small, then we're not going to have as much drug brought into the proximal convoluted tubule. They're going to stay in the bloodstream. So after the proximal convoluted tubule, we move into the loop of Henle. Typically in this area, we can have passive diffusion. So the drug molecules, even those that were brought across with this active transport system, they may be reabsorbed by passive diffusion back into those blood vessels surrounding the renal tubules. In order for them to do that, though, they need to be, I hope you said lipophilic. So we can change that. Sometimes if we are trying to keep drugs in the loop of Henle and so that they're excreted, we can change the pH of the urine for certain toxins and keep them in there, and then they'll be passed out past the distal convoluted tubule and then into the collecting ducts. But they must be lipophilic if they're going to passively diffuse back into the blood system and be reabsorbed. Okay, so we've talked about proximal convoluted tubule and the loop of Henle. There's passive diffusion here, active transport in this system. Once we get to the distal convoluted tubule, there might be some more passive diffusion, but typically once we've reached this point, we are going to then go into the collecting duct and be eliminated as urine. And so that's the final elimination out of the body.